Hello, everyone, and welcome to another exciting Woo You event. Very excited for this one. It is our first vision therapy binocular course. This came very requested from you guys, so I'm really excited about this one. My name is Dr. Stephanie Woo, and I am the host for this evening, and I am the founder of Woo University. And it is now my pleasure to introduce Dr. Donati. Dr. Donati attended the Pennsylvania College of Optometry in Philadelphia, where she first learned about vision therapy by becoming a patient herself, which that I think is so cool. Upon returning to Canada, she had the desire to bring her passion for vision therapy to her own patients so that they did not need to suffer with undiagnosed vision problems. Since that time, Dr. Donati has been involved in the ongoing process of expanding vision therapy in Canada. She was the founding vice president and current president of the Vision Therapy Canada, formerly COVTNR. Dr. Donati lectures to optometrists who are interested in learning more about vision therapy, and she is involved extensively in training vision therapists. Thank you so much, Dr. Donati, for being with us tonight. I'm so excited to learn from you, and welcome.
Oh, thank you so much for having me here this evening. And I'm told that I'm the first Canadian to be part of Woo U, so thank you for that as well. I am very honored to be here. And, you know, one of the things that I love most about vision therapy as a niche area of our profession is the ability to kind of reach so many different patients of all ages. And I think that we are in a very unique kind of time in history with this pandemic, this global pandemic being what it is, and so many people being virtual and being stuck online, and so many kind of exacerbated binocular vision issues that are really coming to light. I think this is a really critical time where we really need kind of all hands on deck from a kind of binocular vision standpoint. So I'm so glad that there is such a keen interest in people learning more about BV and VT. So thank you so much for having me. I have no financial disclosures to make, although I will disclose that I really love vision therapy, and I really love what we can do for our patients. And I think this is one area of optometry where we really do get to change lives. And so I hope that at the end of this, you will have a little bit of a kindled passion for it as well. So we're going to start off our evening with a couple of quick polls, just to kind of see where we are at, who do we have here, and where we're starting from. What are the raw materials here that we're working with? So hopefully you can see one of these options being as what fits you the most. Hopefully we have more in the top two choices rather than in the bottom two. All right, this is exactly where I hoped we would be, with the majority of people kind of being curious about it, never really jumping in themselves. And 9% of you who are already doing VT, I love it. And I'm so glad that you are able to tune in for this, and hopefully you learn a little bit more. For those of you who are either not so much keen or thinking that it's a whole lot of baloney, hopefully that you find something in here that will change your mind a little bit. But for those of you who are kind of sort of interested, almost maybe, let's get another poll here. So if you do not currently offer vision therapy in your office, why not? So I'm speaking to you, 71%. Okay, so another 71%. It's a lucky number, I guess, tonight. Feel that you don't have the knowledge. Okay, awesome. Well, we can hopefully get in on that a little bit. Feeling like it's too expensive to start. I hear that a lot. And this is one of the areas of optometry where there is some equipment that needs to be purchased. And yet it's not really as critical to get the really big ticket items right off the bat as you may think. So we'll talk about this a little bit more as we go through it as well. So we are going to kind of delve a little bit into, first of all, a bit of background. in what are we talking about when we say vision and vision therapy. So let's first talk about what is vision. And if you kind of Google this, or if you look it up in a Webster's or Wikipedia, the definition of vision is somewhat limited. And it talks about basically having two eyeballs that work, or even one eyeball that works. It's the faculty or state of being able to see. She had defective vision. So this is making vision synonymous with eyesight. And eyesight and vision are about as different as hearing and listening. And I think that it's somewhat easier to make the connection that hearing and listening are very, very different things. I think anyone that has children, or perhaps a husband, sorry, men out there, know that just because they hear you doesn't mean that they listened. And this is something that we talk about at our house a lot with our kids. So being able to see and having vision are two very different things. So let's look at kind of a better definition of vision, something a bit more all-encompassing. So a definition from A.M. Skeffington, Arthur Martin Skeffington, is kind of considered to be the grandfather of behavioral optometry. And his definition of vision is the deriving of meaning and direction of action as triggered by light. And it somewhat seems a bit more abstract than just being able to see or having good eyesight. But if we break it down a little bit, what we're talking about is deriving meaning means having experience with something, learning about something. So if we are deriving meaning from something that we've seen, it means that whatever it is that we are directing our attention to is something that we are learning from and making assumptions about and therefore acting on. And this is where that direction of action piece comes from. So when we're deriving meaning, therefore directing our action, it's something that means we have taken in that information and now we are going to do something about it. And so if, for example, you consider the act of picking up a cup of water to take a drink, we really do take for granted how much vision goes into that. So if I'm going to pick up my cup, my water cup, and take a drink, I first have to point my eyes at the cup so that I know where it is. I have to judge how much space there is between my hand and the cup. I'll need to decide what kind of motor action my arm needs to take in order to make that movement. I need to know how wide to open my hand to grip that cup. How much water in it will tell me how heavy it's going to be, how hard I need to grip it. And then I'm going to need to know about how much I need to tip it once I bring it to my mouth. So all of those actions, all of those pieces of information are coming in through the visual process. So it's not simply a matter of, do I have 20/20 eyesight or not? But there's a lot more vision that needs to go into that process to make it successful. So if vision is that much more complicated, then what is binocular vision and how kind of dumbed down has Google made it? So when you Google it, what you hear about binocular vision is vision using two eyes with overlapping fields of view, allowing good perception of depth. And again, it's pretty sparse in its definition. What we're looking at here is overlapping fields of view, giving us depth perception being basically the gist of it. And certainly there are a lot of gray areas between having perfect binocular function and being a monocular human. So there are a lot of places in between where we can go or that we can be in that binocular space. So again, let's look at a bit more abstract, but a bit more all-encompassing definition. And so what I got here was binocular vision is deriving meaning and directing action to the best biological capacity of the organism, under subconscious control with the greatest possible efficiency and the least amount of effort. So again, way more words than just having overlapping fields. But again, if you break it down a little bit, what we're looking at is deriving meaning and directing action, meaning using vision, using our visual process, to the best biological capacity of the organism, meaning with both eyes together being used simultaneously, under subconscious control, meaning without thinking about it, with the greatest possible efficiency and the least amount of effort. So if you have to concentrate on holding your eyes steady, if you have to concentrate on pulling an eye in, this is certainly not a comfortable visual process that's going to be allowing us to use our system to our best biological capacity. So what does that tell us about the visual process? If vision is a constant derivation of meaning and direction of action, then it is an active process. It's something that we are doing all the time. It's not something that passively happens to us. We are not solely passive observers to our world. We are involved in what we see. And if vision is an active process, that it is something that's developed and learned through experience. And at its core, if the visual process is something that is learned, then it is something that we can learn to do better. And really, that's what we're talking about when we're talking about vision therapy. It's talking about trying to maximize our visual process to the best of our abilities. So let's talk about then what is vision therapy. And vision therapy kind of gets a bad rap. And some of it, I think, has to do with just really bad elevator pitches for how we describe it to our colleagues or to our patients. And I've heard it being called a few things: physiotherapy for the eyeballs, or physical therapy, I think you all call it down there, eye exercises, eye muscle training. And these are not really kind of fair descriptions of what vision therapy actually is. But the other thing that you hear, unfortunately, often from our ophthalmology colleagues or from general physicians, pediatricians, is that it's just a money grab, or it's experimental, or it's voodoo. And really, it's none of these things. And when we talk about, well, physical therapy for the eyeballs, that's not so bad. It's kind of descriptive, isn't it? Just kind of doing exercise and then your eyes get better. And no is the answer to that question. And if we look at the convergence insufficiency treatment trial, and I've put the reference down there at the bottom for you if you have not read this study, I really do think you should and become familiar with it. This was a study that was done that was it's kind of allowed us to really say that vision therapy is the gold standard treatment for convergence insufficiency. And it is certainly better than pencil push-ups, and certainly better than this kind of sham or placebo VT. But what's interesting about this is that they took groups of patients who were diagnosed with convergence insufficiency, and they separated them into a group that did office-based vision therapy, a group that did placebo or sham VT. And sham placebo VT is basically, if you can imagine, doing, for example, lens rock with plano lenses, or doing vectograms monocularly. So patients feel like they're going through the process, but they're really not building anything. They're not working to improve anything from that kind of standpoint of increasing vergence ranges or accommodative function. And then the other group got pencil push-ups. And pencil push-ups, again, is a kind of a common thing that if you don't know anything else about CI, at least you can tell them to do pencil push-ups, right? And what's interesting about this study is that it did show that vision therapy is effective in treating both the symptoms and signs associated with CI, and that the effects of vision therapy cannot be explained on the basis of placebo. But pencil push-ups are actually ineffective at improving both the signs or the symptoms. And in some cases, they actually made it a little worse. And the problem with pencil push-ups, the thought process behind it is, if the patient can't converge, you just get them to converge a whole bunch of times, and eventually they know how to converge and they're not insufficient anymore. The problem with that logic is that the patient doesn't have convergence insufficiency because they don't know how to cross their eyes. Okay. And that is kind of an abstract concept to think about. But the patient has convergence insufficiency because they don't know where it is, whatever the it is that they're looking at, whether it's their book or their phone or whatever it is. There is at its core, a misjudgment in the amount of space that this area is taking up. And so just teaching a patient to cross their eyes and uncross their eyes is really not giving them any information about where that object is. And so by teaching the patient to do nothing but cross their eyes, you're basically teaching them a splinter skill. I like to call that lipstick on a pig. It might look nice, but it's good for nothing. And so the patients really do regress very quickly. And so this is where we came to find in the CITT that pencil push-ups were an ineffective treatment for CI. And so this is really the reason why we can't say that vision therapy is physical therapy for the eyeballs or that it's eye muscle exercises, because we're not strengthening any muscles to get the patient to understand space better. Okay, so it is a little bit of an abstract concept, but it is very important because at its core, if you got nothing else out from this lecture, and I hope that's not the case, if you're still prescribing pencil push-ups to your patients as a treatment for convergence insufficiency, it's something you really should stop. However, a little caveat there is I know that there are some insurers in the US, I have some American colleagues that tell me that they're not going to get their insurers to provide coverage for VT unless they have demonstrated that they have failed at pencil push-ups. So silly, but if you have to do it, you have to do it. So what is vision therapy then? If you can't call it physical therapy for the eyeballs, what can you call it? Well, this is the development of the visual process through guided exploration and discovery by means of sequential actions or activities, which are designed to provide the patient with the opportunity to have the necessary meaningful experiences to acquire vision. So again, a lot more wordy than saying physical therapy for the eyeballs. But if you do want kind of an elevator pitch to describe to patients quickly, what's VT? What are you referring me for? What am I doing here? What we're doing is we are doing activities that are going to train your brain how to use vision better. And that's kind of the quickest elevator pitch that I will use with patients if they want to just know in a nutshell what it is. So vision is our dominant and lead sense. It is our brain's way of reaching out into the world in an effort to understand, interact, and communicate. In many patients, the sense is miscalibrated or it's inefficient, and the patient does need to learn how to compensate through other low-level or maladaptations. And so vision therapy is going to train the brain and not the eyes how to use vision so that the maladaptations are no longer required, and the patient is able to use their vision, again, under subconscious control with the greatest possible efficiency and least amount of effort. So who are we doing this on? Who are the patients that are going to benefit from vision therapy? Well, you could make an argument that almost anyone could benefit from having a more efficient visual process, but we're certainly not going to refer every single one of our patients for VT. So definitely you can certainly look at patients with strabismus and amblyopia as being great candidates for VT. Your binocular vision dysfunctions that a lot of people think about, of course, your convergence insufficiencies or excesses, your accommodative issues, your divergence issues, ocular motor dysfunction, your concussion or acquired brain injury. This is something that's gaining a lot more attention more recently. And a lot more research is going into now what are the visual effects of acquired brain injury on the visual process. Something I added in here fairly recently to this course as well is the whole concept of long COVID having these visual consequences. And we are starting to see this new kind of subcategory of patients that are coming in having had COVID and are now experiencing very similar symptoms to what we would expect our brain injury or concussion patients to be receiving. So, there's still a lot of research that needs to go into that in particular to see what, if anything, can be done on the vision therapy front to see if there's any areas that vision therapy can potentially help these patients with. But, if the patient has a vision problem, we have vision solutions, whether, we give it the label as being from a concussion or a COVID or not. Time will tell really if that's something that we're going to be delving a bit more deeply into. And then we have our vision-related learning problems. And these are our visual information processing deficits. And dyslexia is an interesting one. We're going to talk about that in just a sec, but I just put on here, age is not a factor. And especially when it comes to things like strabismus and amblyopia, there are still some of our colleagues, whether it's optometric or ophthalmologic colleagues, who are still telling their patients that once you hit 10 or 12 or 9 or whatever some magic age is, that there's nothing more that can be done. And we know that's just not true. Just, hard stop, that's not true. And so we want to make sure that regardless of the age of the patients, and yes, even adults, we can make really big changes in their lives through vision therapy if that's something that they want to pursue. So let's talk about dyslexia a little bit, because this is an important one, because I think that sometimes VT gets some flack for saying, oh, you know, if you have dyslexia, come and do VT and we'll train that dyslexia right out of you. And I mean, dyslexia is a neurological condition, it's a neurological problem, and vision therapy will not cure it. Just like we are not going to do vision therapy to get rid of someone's hemianopia. We're not doing vision therapy to get rid of someone's, retinal damage. This is a biological, pathological process that we're not going to be able to remove through vision therapy. However, there are many, many diagnoses of dyslexia that are just incorrect. And that might be because the patients were tested assuming normal vision. And if the only thing that the patient got out of their eye exam was that they see 20/20 and they don't have any problems on their dilated fundus exam, then we really don't have any idea about how their visual process is functioning. And so this is something that I feel the psychology profession needs to be able to distinguish a little bit more between patients that have just had a sight test and those who have had a proper eye exam. And just standing in front of the paper chart at the pediatrician's office and saying, oh, they're 20/20, therefore they can have this test done, that's not going to cut it. And this might be the same with patients diagnosed with ADD or ADHD as well. So vision therapy is going to treat the underlying visual problem that may be contributing to the patient's difficulty with reading and language, but it is not going to cure them if they have dyslexia. Now, one of my professors at PCO, I'll call out Dr. Andy Gerwood, he always said, every patient is entitled to more than one disease. And I remember that to this day. And absolutely, you can have a patient that has dyslexia and an accommodative problem. They have dyslexia and CI. So just because they have this label of dyslexia, it doesn't mean that VT can't help them if they do have another underlying vision problem. So we do have to be very careful with what we're promising our patients as well. If they're coming in saying, oh, I heard that you can help my daughter because she has dyslexia, well, I'm not making any promises. We need to do an exam. We need to see if there's anything else going on. And the other question that I always ask these patients is, okay, so you have a diagnosis of dyslexia, according to whom? Because if it's just, my dad had dyslexia and grandma says I'm just like him, that's not really the kind of diagnosis that we're going to be able to hang our hat on. So just keep that in mind, that sometimes these diagnoses are incorrect, and we should not let that be a barrier to care if the patient does in fact have a visual problem as well. So hopefully you're getting a little bit more curious about how this could work in a primary care setting. And I do get a lot of referrals from colleagues saying, there's this weird case. I don't want it. You take it. It seems like something weird that you would do. And that's fine. Really, I don't mind. But there's so much that I get from our colleagues that I think, this is something that absolutely you could have managed yourself in a primary care setting, and something that you can do so much lens work that's kind of a passive form of vision therapy. And so we'll go into that a little bit more now when we talk about testing. One of the things that I heard from a friend of mine who practices in Boston, who does VT a lot, is, he said, I was having lunch with a colleague that I hadn't seen in many years, and we were at an association meeting, and she heard that I do VT, and she said something on the lines of, oh, I never see patients like that. And he said, you're probably right. Maybe you don't see them. It doesn't mean that they're not there, but recognizing them is a whole different thing. So hopefully we can get you guys recognizing what these are when they come into your office. So we'll start with some history, and history is very overrated, but you've heard in optometry school, history starts when you go get the patient from the waiting room. And it's very, very true. And some of these things, especially in VT, we can see it from a mile away. So looking at your patients, if you see strabismus, well, then you know that this is a patient that has a binocular vision problem, right? They're wearing the problem on the outside, and you can see that very, very easily. And these are often the easiest cases to get into the vision therapy room because it's pretty obvious to the parents, it's obvious to the teachers, it's obvious to friends that this is someone who has something funky going on with their eyes. And so there's really not a whole lot of discussion about whether or not there is a problem. The question then becomes, how are you going to deal with it? Now, as far as working distance goes, this is something that's becoming more and more obvious. It used to be that patients would come in and they'd sit in the waiting room and watch the TV up on the wall. And really, I don't know why we still have that thing up there wasting electricity, because everyone has their own device and everyone is looking at their phone. And so with kids especially, we get to see how are they holding it. And if they've got their nose almost touching the screen, or they've left a nose print on the screen, we know that there's very likely something going on there. And at least it gives us the opportunity to counsel these people on visual hygiene practices. Look at the posture in how the patient is sitting, how they are holding themselves up. And we don't just see that in the waiting room, we see that in the exam chair as well, right? So sometimes patients will come in the exam chair and they kind of, slump over to the side, and you have to keep asking them to sit up tall. These are kids who are going to be at higher risk of having binocular vision issues as well, and perhaps even some developmental visual issues. Check out physical compensations, things like winking, head tilts, or head turns, or this deep blinking that we see a lot more of now, like this really heavy blinking where we say, mom comes in very concerned because she's noticed this thing and what's going on, is this a tic? These are all things that can give us cues to poor binocular function. Now, when it comes to our screen use, and for those of you who are American, likely you have not seen this particular issue of the CJO. This is the Canadian Journal of Optometry. So for any fellow Canucks, you'll be able to pull this up fairly easily. I put the reference at the bottom. I don't know if you have to be a CAO member to be able to access this. Don't mind the mosquito, that's just the cover of the issue that this happens to be in. But there was a joint policy statement, a joint position statement, between the Canadian Association of Optometrists and the Canadian Ophthalmological Society on the use of electronic screens in children's vision and recommendations for safe use. And what's really interesting is that this actually came out in 2018. So this was before COVID. And some of it, all these recommendations, unfortunately, kind of went out the window with COVID. But what the results were, what the recommendations were, was that between, and I know this is kind of small, hopefully you guys can read it a little bit, but between 0 and 2 years of age, no screen time, 0 hours of screen time is recommended, with the possible exception of live video chatting, so Skype or FaceTime, with parental support for the potential benefits of social development. But otherwise, they were saying no screen time, no baby Einsteins, nothing like that. Between 2 to 5 years of age, no more than 1 hour per day. So 5 years old for the Canadians, that would be your senior kindergarten. For Americans, I think it's just 1 year of kindergarten when we would have senior kindergarten. So if you did kindergarten completely online, or the majority of it was online, you've already quadrupled that, if not more, depending on how long the school day was for you. So that's kind of gone out the window with COVID. Between 5 and 18 years of age, ideally no more than 2 hours per day of recreational screen time. And again, because of COVID, how much social time, social networking is done completely online now. And so some of these recommendations are just, almost laughable, unfortunately. But it does give us at least something to strive for as things maybe begin to return to normal a little bit, that we look at doing other activities that are outside of the screen. And so the other nice thing about this policy statement is that there's other recommendations for things like screen use before bedtime and other things like that. So it is really worth a read. I actually kind of photocopied this and sent it out to be put on a tear-off pad, so that if there's patients who are really, really going above and beyond these recreationally, not related to school, but recreationally, I can kind of tear that off and circle the age group, so at least they have something to kind of go off of there. So in terms of these physical compensations, winking especially, there is really no reason why a child should be winking while they're reading. There's no other benefit other than to relieve double vision or to relieve visual confusion. So if you're seeing a patient winking a lot, first thing I do is ask them, oh, that's a neat trick. Can you wink the other eye? So if they can wink one eye, but they have no idea how to wink the other eye, that kind of gives you an idea about which eye is the problem one, number one. But also, especially if you're looking at a child this age, someone who's kind of 2 years old or even less, they really should not know how to wink yet. So if they do, that's a pretty big red flag. But winking should make you suspicious of diplopia. Your head tilts should make you suspicious of vertical or oblique issues. Your horizontal head turns. So if a parent says, you know, my son watches TV with their head turned to the side, I hear that a lot. This should make you suspicious of some kind of hidden phorias, high angle phorias, or even some intermittent tropes. And your vertical head turns should make you suspicious of more A or V pattern deficits. So make sure that you're checking your cover test in all positions and making sure that you have something that is equal in all positions of gaze. So the history questions, we've all got our own kind of battery of history questions. And the purpose of this is really not to, make you change too much what you have, but maybe just to kind of take notice of some potential areas where we can improve our history taking to kind of filter out any of these potential BV problems before we've even done the exam. So if they had birth trauma, if there was a rapid or forceps delivery, if the patient spent any time in a NICU, these are all things that may lead to increased risk of binocular vision or visual developmental issues. If there are hearing issues, particularly if there's a hearing issue on one side, some kind of independent research that I did and some case studies and things kind of have led me to the understanding that especially with unilateral hearing issues, especially early in life, there's increased risk of amblyopia for these patients. So things that I ask for now is, did the infant pass their newborn hearing test? And if so, in both years or in just one? Did they crawl? And if they crawled, was it on all fours or did they kind of bum scoot? Did they walk on time around 12 months or was that delayed? Was there a speech delay? Is there any academic concern? Is the teacher concerned about anything? Because sometimes the teachers are more concerned than the parents are, or vice versa. Is the child known to be clumsy? Can they ride a bike if that's age appropriate? Can they catch a ball if that's age appropriate? Any history of concussions? All of these things, again, they're not going to give you definitive information about whether or not there's going to be a binocular vision issue or a visual perceptual problem, but it's certainly the more boxes you're ticking here, the more red flags are going off. So let's look at our examination, and this will kind of bring up another poll for us. So hopefully this is a wakey time for you if you were starting to nod off. Which of the following do you perform on most or all of your non-presbyopic patients? And again, let's see where we're at. Hopefully you find something in there that suits what you're doing in your practice now. Okay, good. So I'm excited to see that you guys are doing cover tests in stereo on the majority of your patients. Sometimes when I deliver this, I get almost everyone in the top. So we're doing pretty well here. I'm happy with this group, yay. All right, well, let's talk a little bit about visual acuity testing. And we're not going to reinvent the wheel here. Everyone's got their own kind of methods on how they do this and which eye goes first and what the what the plan of attack is here. But really what I want to do is kind of discuss kids a little bit more specifically, and really to make sure that we are looking at who are we doing this exam on. Now I've put up the Allen card here. And this is the one with the hand and the duck and the phone. And I know this one's really kind of fallen out of favor because of the fact that there is inconsistent spacing, that the optotypes are not fairly equal. And so there is a bit more or less demand depending on which figure you're actually looking at. But I actually really like using the Allen card. And what I do with my with kids is I will actually start OU. So I will not have them, I start at near and I will start OU. And what I'll do is I'll start at the very top of the card for the biggest ones. And I just want them to go through and name what they are, because I want to make sure that they're calling it either what I would call it, or at least assigning it a label that I can use again in the future. So for example, I had a child who was 6 years old who pointed at the duck and called it Fred. And I said, Fred, he has a name? His name is Fred. And the mom kind of laughed and said that they had a pet turkey at home and the turkey's name is Fred. And so when she looked at that picture, to her, it looked like a turkey. And so she called it Fred. And that's fine, because now I can use that language with her as well. So if I have this young lady who is now going to be very shy, and I say, tell me what other pictures you see, and she doesn't want any part of that, I can say, okay, well, can you show me, is there another Fred? Is there a littler Fred? Can you find all the Freds? And then she can kind of just point. And so there's other ways to kind of tease out that visual acuity for patients who are maybe not the most excited to be there or who are a little bit nervous. And the more you can kind of engage them into something that's fun, the more you can get out of them and the more testing you're going to be able to get and the more reliable information you're going to be able to get. So I like the Allen card. I will certainly not challenge anyone who says the Leah is the only way to go, but there are only 4 choices. So, you do you is what I'll say there. The Leah paddles, I really, really love for, of course, age appropriate. You're doing that probably around a year or less for preferential looking. When you're getting up into the toddlers, I really like being able to kind of match. So I can point to the duck and say, can you find the baby duck? And you can even skip all the way to the very, very bottom line if you want to. And that way, that if they only find one and it's the smallest one, you can kind of move on. The key thing for these little kiddos is you got to get in and get out. You can't spend too much time going through every single character, and it just takes too long, and they're going to get bored and they're going to be done. And you want to make sure that you're able to get as much as possible. So that's really why I like to do near first, is because I can make sure that I have the labels down so that when they are now looking in the distance, they are able to kind of compare apples to apples, and we can use the same thing in the distance. Now, my preference for grade 3 and up is going to be for continuous text. And really, once we hit grade 3, so there's a switch between grade 2 and grade 3, at least up here in Canada. Grade 2 and below, we're really emphasizing learning how to read. But then once we hit grade 3, the big switch happens, and now we're kind of reading to learn. So rather than learning to read, we are reading to learn. And so I want to make sure that we're incorporating that into the visual process as well in how we're evaluating them. And so I will give them a paragraph to read. And the one that I use is on the University of Waterloo card. I don't know if you guys down there have that. I also have the Lighthouse continuous text, but for a grade 3 student, that's a little bit advanced. But what I'll say to the patient is, I want you to read the little story here at the top. And if you come across any words you don't know, I want you to just spell them out for me. Just tell me what letters you see in the word. So it gives me kind of a little bit of an indication, where are we at from a reading perspective? So if I have someone who's in grade 5 and they have to spell out a whole bunch of words, now my kind of spidey sense is tingling a little bit, thinking, why are we struggling in grade 5 to know what the word street is, for example? So the more you can kind of engage them into a reading task, the more you get to see what that's like for them in a real world environment. And again, it will let you decide if there's more or less red flags. So your cover testing, I put this picture up on purpose because I really like the frosted occluder. Now this frosted occluder looks like this is not an occluder at all. You can see the eye perfectly. There's nothing occlusive about this. This is actually very, very blurry to look through. You would really not be able to see the 2400 letter looking through it from that side, but you can very, very easily see the other eye, which is great for cover testing because you can see what's happening underneath the paddle. So if your patient is really not paying attention, so especially when you're using your near target, and I like to use Wolf wand, we'll talk about this a little bit more. If you're doing your near cover test and you get the impression that they're really not looking at it, I mean, maybe their eyes are pointed at it, but they're really not paying attention, you can actually kind of just give it a little bit of a wiggle. And if they are actually following it, then you know that they were actually looking at it. If you wiggle the occluder, or excuse me, the fixation target while you're doing your cover test and they don't track it, remind them, I want you to look here, look here. So the little wiggle is a nice way to make sure that you are really getting their attention. One thing that I do in my spare time, is I'm an assessor of clinical records for our college, our provincial college of optometry. And one of the things that drives me absolutely bananas when I'm reading other of our colleagues' records is that out of 25 records that I'm assessing, every single patient is ortho at distance and ortho at near. Ortho, everyone's ortho. And really what that tells me is that either your patient wasn't looking or you weren't looking, because it's actually not common for patients to be ortho at near. So really what we're expecting in the distance is between 0.5 and 1.5 prism diopters of exophoria, which you're really not going to be able to detect with your naked eye. And so ortho is certainly expected. But at near, our patients, we should be expecting between 4 to 6 diopters of exophoria. And so if your patient is actually ortho at near, that's telling me that they have lost their exo, and that might not be a good thing. So let's talk about that a little bit. So think back to optometry school, we talked about, or we learned about accommodative leg, right? The leg of accommodation, the normal leg of accommodation being about a plus a half, right? And that plus a half really kind of gives us the ability to switch or to kind of move freely between where our eyes are postured in relation to the object, so that it gives the patient a little bit of an accommodative buffer to be able to accurately fixate on that point in space. And so if we have a lag of accommodation of plus a half, it means that our accommodation is postured slightly behind the target that we're looking at. And that means that our posture, our visual posture, will work out to be about 4 to 6 diopters of exophoria. So if you are actually having an appropriate amount of lag, that 0.5 diopter lag of accommodation, that's going to equate to about 4 to 6 diopters of exo. So those two things really should match up. And just as we learned in optometry school that if your patient has a lag of accommodation of plano, then we called that a lead of accommodation. And we said that's an abnormal finding. And in very, very much the same way, true ortho at near is a type of ESO, and it really does need the same intervention. So just consider that when you're measuring your near cover test, actually give it a second and look, because there is going to be a small amount of exos for the vast majority of our patients. And we have to make sure that we're noting that down, because it can and does change as your patients move into myopia, or if their myopia increases, or they start to emmetropize, that amount of phoria is going to fluctuate. And so we're not going to recognize these kind of early red flags if we don't have accurate information in the first place. So just something to keep in mind there. So your fixation and pursuit in saccades, this is something that we should definitely be measuring when we have concerns. And so things that might give you concerns are, for example, if the patient was reading poorly when you gave them your continuous text, if there are history concerns from an academic standpoint that things are not going well, or if, let's say, they have a tutor and the tutor suggested that they get checked for tracking problems. These are all reasons why you would want to include these into your testing, but perhaps you may not do things like saccadic testing on every single patient. But one thing that we do on all of our patients is your vergence, right? Your ocular motilities. And so it's very easy if you're already doing that to throw in a really quick pursuit assessment. It really takes very, very little extra time. So let's talk first about what we are going to be using. And this is a wolf wand. And it has, this particular one has a gold ball at the top, but you can get them with silver, or you can get them double-ended where there's a ball on either side. This is a nice target. And I really like the wolf wand really because of how reflective it is. It actually makes it a kind of irregular accommodative target. So if someone's very myopic, they'll actually be able to accommodate to their own reflection in the ball. If someone's very hyperopic, the ball itself is going to be accommodative enough. And so there is some variation in there, and the patient can pick out as much detail as they like. And so I find it really useful for a lot of variations of patients. If you have a very small letter E on the top of a stick, and your patient is hyperopic, they may not be able to really resolve that very well, and they may be pumping in a lot of extra accommodation just to resolve it, and you're going to get artificially ESO'd cover test results. So just something to keep in mind. But when we're assessing fixation, it's as simple as, before you start your cover test, just say, look at the ball and just see if they can, okay? Can they put their eyes on it, and can they hold their eyes on it? And we're not talking about a whole minute here. We're talking about 5 to 10 seconds. Can they actually just look at it? Or do their eyes start to kind of shift or vary or move away? And if the patient is not able to fixate on a steady target, how the heck are they supposed to be able to resolve something when they're trying to read? How are they supposed to be able to look at the teacher at the front of the classroom if they can't keep their eyes steady on the blackboard? How are they supposed to make eye contact and learn that the kind of proper social behaviors that we expect them to be able to learn? So there's a lot of reasons why fixation might be a problem, and we'll talk a little bit more about that later. In terms of pursuits and saccades, what we're looking to measure is their ability to do the test, how accurately they do it, and whether or not there's any head and or body movement. And a really easy way to kind of do this that's quite standardized is using the Ensuko scoring. And this is a very, very busy slide, and certainly you don't have to memorize this. This is very Googleable. So feel free to just Google Ensuko scoring and you'll be able to find this. But it gives you criteria, scoring criteria for being able to tell or being able to judge how the patient is able to perform for saccades and pursuits. So for pursuits, again, using your wolf wand, what you're going to be doing is you're going to be moving the target around in a circular direction. Okay. And then you're going to reverse direction, and you're basically just watching how are they able to track that target. Do their eyes keep falling off? Do they keep blinking? Do they lose it and have to find it again? Do they move their whole head as they're doing that? And so you're going to, based on how they're able to perform, you're going to give a score, separate scores for ability, accuracy, and the amount of head and or body movement. So if they were able to complete 2 rotations in each direction with no refixation and no movement of head or body, then you would score the pursuit as 555. When you're doing saccades, I actually really like the double-ended wolf wand, and that's not what this one is, but if you have the silver on one side and the gold on the other, you can actually just have them jump back and forth, and you're going to do that 10 times. And again, the same thing. Are they moving their head to track that? Are they able to do it without under or overshooting? How accurate were they? And you can set your scoring based on that. So that's a nice, easy criteria to use. For your near point of convergence testing, and again, this is something that we really should be doing at every single exam. And remember, if you're doing you just did your distance cover test, now you've done your near cover test, you're going to do your vergence, whatever method you learned in school, do your quick pursuit. And then after you've done your 2 direction or your 2 circles in each direction, then just go in and do your NPC. That whole battery of tests took no more than 60 seconds. So it's really, really easy to incorporate into your everyday exam. And, why shouldn't we? It gives us a lot of information on how the patient is able to perform. And if you have never diagnosed convergence insufficiency, it's probably because you've never measured the patient's ability to converge. So if not, then that's a really easy thing to add in to your exam starting tomorrow. So we like to use the wolf wand again. I don't really like to use a letter target, only because the more accommodative you make the target, the more the patient is potentially relying on accommodative convergence. And so we want to really, as purely as possible, measure their ability to converge inward. And so we want to make sure that we're doing that with something that's fairly accommodative, but not solely accommodative. So yes, to the nose is normal, but 5 centimeters is also normal. And also don't forget, when you are recording your near point of convergence, you're not just recording when they went double or whatever that break point was, you also need to then pull back and note what that recovery position was as well. Now, we know that we should be recording our break and recover, but also don't forget to record all the little juicy extra bits, such as, their eyebrows went down, they were holding their breath, they were grinding their teeth, their whole face turned white, they were making this. All of those other things are telling you that, yeah, maybe they can converge their eyes, but at what cost? Okay. If they're shaking and turning red and their eyebrows are halfway down their nose, this is not something that they are going to be doing on a regular basis when the teacher says, here, read this. Okay. They're going to be like, yeah, no, forget it. They're doing it to put on a show for you because you've asked them to, but are they going to do that in real life? And I would say the answer to that is likely no. Stereopsis, this is another thing that sometimes falls out of our battery of testing for some reason after optometry school. And I implore you to bring it back in, only because this is, again, another method of kind of assessing the patient's binocular status. And it's also something that can change throughout the patient's life and throughout visual stresses. So if they were 20 arc seconds of stereo in 2019 and you see them in 2021 and they're at 70 seconds, something's changed, okay? Something's going on there. That in and of itself is a red flag. And certainly if you're going to be starting to offer treatment for some of these issues in your office, you want to know that it's helping. And so reassessing stereo is going to be a great way to tell you about improvements that are made. So you can start stereopsis testing on your, what do you call those, your 6 months exams, infancy, right? I think you guys have infancy. So you can do that in an infancy. And the one that I like to use, and again, no financial disclosures, this is the Burnell dyno that you're seeing in the picture there at the top. And what I love about the dyno is that you do not need glasses. And sometimes the really little kids find those glasses terrifying. Sometimes they find them awesome, but sometimes they find them really terrifying. And, you try to put glasses on their face, and next thing you know, their face is buried into dad's neck and the exam is over and they're petrified, right? So this is something that is much more approachable because there's no glasses, but also he's really friendly and he's really cute looking. And I really hate the fly because a lot of kids are scared of the fly. They think it's gross and they don't want to look at it. And the problem with the butterfly is it's somewhat abstract, right? There's no form on it. If you don't have kind of good global stereo, you're not going to be able to tell. You'll be able to see that something's popping out, but it's hard to see exactly what it is. So the dyno is really great for that. He's really friendly looking, and 6-month-olds, they love to just reach out and try to pet his nose or grab his nose, and they find it really approachable. So I like it a lot. The random dot stereo test that you're seeing on the bottom there, this is a new one that's come out fairly recently. And what I like about it is that the whole test is random dot rather than using the word circles. So depending on what vintage you are as an optometrist, your stereo test might have the kind of diamond shape with the 4 circles, top, bottom, left, and right, or you might have the horizontal bar of 3 circles, left, middle, right. And those are fine. The problem with the word circles, though, is that you can pretty much guess what the answers are, even without glasses on, to about 70 seconds. So for your amblyopes, for your strabismus patients, it might be giving you a false sense that the patient has stereo when they actually do not. So again, no disclosures, but I really do like these new tests that have come out from Burnell. because they do have that 100% random dot, and the dino, again, he's super cute. So your worth 4 dot testing, and again, this is something that I would do either in a binocular vision assessment, or if in a routine exam, if I was suspicious of something in particular. But this is an important test to do at both distance and near. And another thing that I like to do with it is after I've measured it at distance, so I put up my distance dots, and I'll ask the patient how many dots they see, and I ask them how many of each color, okay? We like, of course, in a perfect world, that we are going to see that 2 green, 1 red, and a gold, or orange, or whatever, brown, whatever color they describe luster, that would be great. But sometimes you might hear that they see 2 red and 3 green. Sometimes you hear just 2 red or just 3 green, indicating suppression. Uncommonly, you're going to hear patients say that they see 2 green, a white, and a red. And if the patient tells you that it's white, first things first, check to make sure the glasses haven't slid down their nose and they're just not looking at the target. But what I'll do is I'll present the target after they have put the glasses on, so that they're not seeing my target before they put the red green glasses on, because it does kind of mess them up a little bit into thinking that what they saw was normal and what they see is not normal. So just kind of keep that in mind. Then I like to reassess it with a ±2 flipper. So after I've put the distance target and I've said, okay, they're fused, or 4 dots, whatever it is, then I'll put up a -2 and a +2, and I'll see if there's any differences. And what I like about that is basically what I'm doing is I am forcing the patient to change their accommodation, and seeing if it changed their vergence. Okay, so if they were fused and I gave them -2 and now they're seeing diplopia, well, that tells me that when I stress their binocularity, that it kind of falls apart. So it just tells me that they're kind of towing the line a little bit, and that they may be at risk of developing issues if kind of the going gets tough. Pardon me. The other thing that you can do with the worth 4 dot is it can give you an indication whether or not anomalous projection is present. So if you have a patient who has a constant unilateral strabismus and they report seeing 4 dots, then you know that that is anomalous projection. We'll talk a little bit more about that coming up. Now, the other reason that I'd like to ask what colors does the patient see is because this is an example of someone who says they see 4 dots. They see 3 green and 1 black, okay? And seeing 1 black is important because what that's telling you is the patient is suppressing their right eye, assuming the red is on the right eye. So this is a patient who is suppressing, and your glasses don't cancel 100%. So it might be time to invest in some better equipment that cancels a little bit better. But sometimes your patients are just kind of really keen to notice that little outline that doesn't cancel 100%. So if they see 4 dots, don't just call it a day. Ask about those colors, because they may be kind of deceiving you, and actually what they're doing is suppressing. So just something to keep in mind. So your lag of accommodation here, again, this is the difference in dioptric power between the object and the plane of accommodation. And we talked about this a little bit already. We expect there to be about a half diopter of lag, and that corresponds to that small amount of exophoria at near on your cover test. And again, anything less than 0.5, it's considered to be a lead of accommodation. And there's a few ways of measuring that. Depending on where you went to school, you probably have a preferred method. You may have learned MEM or Bell. These are both retinoscopy methods, or your fused cross cylinder, BCC, I think, is what Waterloo grads call it. Depending on where you went to school, you might have a different version of it. But essentially, this is kind of how it goes. And this is my favorite because I already have them in the phoropter for other things. And yes, even little kids, you can get them to do this test. You just have to be creative in how you describe it. So what you're going to do is you're going to keep normal room illumination. It used to be that it was described that this should be a dim light situation. It really doesn't need to be, but just make sure, because if you're doing this test and you're using that near rod that comes out of your phoropter, depending on where your overhead lighting is, that near rod may actually be casting a shadow right down the center of your target and making the vertical lines appear dimmer than they actually are. So if that's the case in your setup, then yes, dim your overhead lights, but otherwise it's really not necessary. You're going to make sure that your phoropter is set to the near PD. You're going to dial in on your auxiliary knob that plus minus 50. So the knob at the top next to where your occluder is, or your red lens or your ret lens or whatever. If you have an automatic phoropter, those are all different. You'll have to kind of consult your manual on how to set that up. But you're going to make sure the patient's tentative RX or the subjective RX is still in your phoropter when you do this. And you're going to present the crosshairs. And the question to the patient is, which lines are bolder or darker? The vertical, up and down, and I'll actually gesture in front of the card so they can see up and down, or horizontal side to side. You'd be surprised how many adults even don't know accurately what vertical and horizontal mean. So I always say side to side and up and down as well. And if they say that it's the side to side, the horizontal that's darker, then you're going to add plus. If they say the vertical is darker, you're going to add minus. And you're going to find, ideally, when that kind of levels off and both are equally bolder or equally dark. You might hear some other weird responses. Sometimes they say that, oh, well, the orange ones are bolder than the blue ones. It's like, well, they're, obviously they're not colored for you. The patient is seeing them that way due to some sort of weird diffraction or accommodation through the lenses. But just reiterate to the patient, we're looking for boldness. So the color doesn't matter, just tell me which one's bolder and kind of leave it at that. Or if they say that it keeps changing, so it's, it's horizontal 1 second, it's vertical the next second, and they're not really sure how it's landing. To me, this is someone who is asymmetric. And what I would do is actually dissociate the patient so that I have 2 separate crosshairs. And now I'll just have them direct their attention to the one and direct their attention to the other and find where that levels off and record it as the unilateral fused cross cylinder or UFCC or UCC, again, depending on what school you might have different abbreviations for that. For your fusional vergence ranges, so this is going to tell you how much vergence flexibility your patient has if their accommodation remains stable, because you have them looking at a single point in space, right? On your near card, the amount of accommodation is remaining stable. What you're changing is the vergence demand. So the way that you ask this question is important, because if you say to the patient, tell me when it blurs, breaks, or recovers, what they are going to tell you is when it blurs, breaks, or recovers. They're not going to tell you anything else that they may be observing. And so you're going to miss out on things like, oh, it's getting further, it's getting larger, it's coming closer. And those things are really telling you how the patient is perceiving their space. So are they perceiving it accurately in a silo or inaccurately as soli? Remember that from optometry school. So if you are not actively providing vision therapy in your office, whether or not they're seeing silo or soli maybe is not of too much value to you. But if you are providing VT in your office and you know that this is a patient that you're going to be working with, it is really important to kind of note what you're starting out with, so that as their patient is learning to appreciate space better and they do start to make those changes, then you know they're definitely heading in the right direction. So the numbers themselves on what they're getting in blur, break, or recovery is not super, super critical. And you really don't need to memorize a whole bunch of norms. And if this is kind of what's been holding you back from getting into BV is because you can't remember everything that's normal, hopefully this sets you free a little bit. But just kind of take note of the relationships. Ideally, we know that our base out is going to be higher than our base in, okay? We know that near is going to be larger than distance, and that the blur and the break should be fairly close together, within maybe 6 or so prism diopters. But it's not critical and it's not crucial that they meet specific cutoffs, okay? Also, it's important to not take too much stock in whether they recovered too close to where they broke. So if they blurred at 10, broke at 12, and recovered at 2, I'm not horrified by that, versus if they broke at 12 and recovered at 8. We can't make judgments on those particular numbers without context of what that means to the patient. And so just kind of be careful not to draw too many conclusions. Yes, if the patient has a really low base out, so if they're breaking at 6 in the base out, but on the base in, they break at 24, yeah, that's something that's important. That's of note. That is definitely something that's going to be causing them issues. But if they broke at 8 instead of 6, or broke at 10, those are still concerning when you compare it to the base in break of 24. I hope that makes sense. If not, we can discuss it more in the question period. Now, when you do your phoria testing, this is where you're going to be dissociating the patient. You're going to have them look at that near target. Ideally, it's going to be your little block of near letters. And you're going to ask them to draw their attention to the lower, in this case. And you're going to say, tell me when the upper image lines up directly above it, like buttons on a shirt. Or if it's a young child, then I'll have them look at me first before they look in the target. And I'm going to say, I'm going to show you one picture here and one picture over here. And I'm going to move one of them. I want you to tell me when they line up, one right on top of the other, so that they can actually see what it is that I'm talking about. Once you have got that near phoria especially, I like to remeasure it quickly. If I have a tentative add in my mind, then I'm going to check it again and see if there's any change to that phoria. So if I've done my FCC, my fused cross cylinder, my lag of accommodation, and I found 0.5, for example, then I might throw that in as an add onto my subjective and quickly remeasure that phoria and see if there's any difference. And we'll talk a little bit about that when we get into the prescribing. So NRA, PRA, or BPA, BMA, depending on where you went to school, this is the relative accommodation. So adding plus and minus at near to your target. So this is going to be done over your tentative final RX, and you're going to add in your minus and plus. And this is going to show you how much flexibility and accommodation your patient has when you keep vergence stable. So this is a little bit different. It's kind of the opposite if you think about it from your vergence, where you are keeping accommodation stable and changing the prism demand. Now we are keeping the prism demand the same and changing accommodation. So we're looking at it from a different standpoint. And ideally, it should be about 3 diopters in either direction, again, in a perfect world, but we don't live in a perfect world. So generally, I would be concerned if my patient's PRA is less than 2 diopters, meaning if it's like minus 150, if it's minus 175, I would be certainly more concerned versus if it was minus 250 or minus 275. I would also be concerned if there's less than a 4 diopter range between the NRA and the PRA, the negative and the positive relative accommodation. So if I have a PRA of -2 and an NRA of plus 175, then from the PRA to the NRA is only 3 3/4 diopters. So that's a restricted range. So if your patient has a low PRA, meaning they're not able to take a lot of extra minus, first of all, this might be your first cue that you've over minus your patient on your subjective. So keep that in mind, something to check into for sure. And if not, it could be that your patient is experiencing near point stress, and this might be a good reason to get an add on them. Okay, so let's talk about cycloplegic refraction a little bit. Depending on what state or province you happen to be in, every college, every area has their own reasons or kind of guidelines as to when cycloplegic refraction needs to be performed. And you should definitely follow that advice and make sure that you do your cycloplegic refraction whenever it is that you are supposed to do it. But I would like to challenge you a little bit in your thinking as to what you do with those numbers once you've measured them. Because again, we kind of get it drilled into our heads that when we get the cycloplegic refraction, that this is the real prescription, or this is the true prescription, or this is the prescription that's the best one that I would never have been able to get on my own just with my retinoscope. And I don't trust what I measured. I only trust my cycloplegic. What it's really telling you when you measure a cycloplegic refraction, the numbers you are getting, this is the maximum amount of plus in the eye under cycloplegic conditions. That's all. Okay, it's just another number. It is not the prescription sent from on high. Okay, the way that I like to think about it is this. Imagine that you buy a new pair of pants. Okay, it's a weird analogy, but I think it is apt. Okay, so you got a new pair of pants. They're way too long for you, and you need to go to a tailor and you need to get them hemmed. Okay, if you go to your tailor and you bring the shoes that you're going to be wearing every day with these pants, and he says, okay, I'm going to pin them now so that I can hem them. I'd like you to get up on your tiptoes as high as you can. Okay, and he pins them and he hems them while you are on your tiptoes as tall as you can possibly get. Well, how helpful is that going to be when you go home and you're not on your tiptoes anymore? Are your pants going to fit you right? Okay, and we're going to talk about this more when we get into the prescribing section. But really, I just kind of want to put this out there for you as just some food for thought for now, to say, when we are measuring the cycloplegic refraction, we are measuring the maximum amount of plus in the eye under cycloplegic conditions. What we do with that number is up to us, okay? And we'll talk more about that soon, but just to start baking your noodle a little bit. So let's talk about diagnosis. So strabismus comes in a number of different flavors. You can get your constant, intermittent, your unilateral or alternating, ESO, exo, hyper, hypo, a lot of different possibilities there. And these are our X and Y axis deviations. So remember from grade 10 math, right? Your X axis is along the horizontal, your Y axis is on the vertical, and your Z axis is the one that comes out from you as the center. So coming out from you and going behind you. So our strabismus and amblyopias, strabismus anyway, I shouldn't say amblyopia. Strabismus is normal during the first 4 to 5 months of life, while the infant is still trying to figure out how to operate those extraocular muscles. They can do a lot of funky things with their eyes, and we don't worry too much about it. But if it's starting to hang around into the 6th month and beyond, then we would call that a strabismus. As far as the angle of it goes, you can have your microtropias, which are around, less than 10 diopters, prism diopters of turn, your mid-angle tropes, so around your 15 to 25, and then your large angle, or those so-called enormotropes, where the eyeball is kind of buried into the side of the nose there, or turned quite far out. Rule of thumb, and again, it's not steady across the board, but the general rule of thumb is, depending on how large the angle of turn, that will tell you approximately how old the patient was when they developed it. So if the patient has that really deep esotropia right into the corner of the eye, this is really a very early onset strabismus, versus a microtropia, which can be even 12, 13 years of age, or even beyond sometimes. If your patient has an intermittent strabismus, okay, or an alternating strabismus, they should not be considered surgical candidates. Please do not send these folks for surgery. If you have an alternator, they're going to become unilateral. If you have intermittent, they will become constant. This is just what happens. And unfortunately, sometimes that message does not get to the patient, and the parents can be very, very distraught afterwards when they did surgery hoping to eliminate something that happens every once in a while, and now it's just there. So just keep that in mind. These are patients who respond very well to VT, and it's a non-surgical, and it certainly has much longer lasting results than the majority of the surgeries, excuse me. So just something to keep in mind. Now, as far as the onset, we have to be careful here, because we do know that if you're kind of getting into the 6 years old area, and you're getting a new onset strabismus, these should make your spidey sense start tingling here. If you are getting a strabismic patient where the strabismus is new, they might have kind of got it when they woke up one morning, or got it following a trauma, or it occurs with pain, or there's pupil abnormalities, or any other kind of red flags for pathology. These are not VT candidates. Don't refer them to your local VT person. These need to be medically cleared first before anything else is done. So keep that in mind. You can't do VT on a brain tumor. It does not respond well. These are people that need to be in the appropriate hands. So make sure that you are kind of doing your due diligence. And especially with amblyopia, remember, this is a diagnosis of exclusion. So make sure that we are not missing anything that is critical here. So why is this happening? Strabismus especially, what's going on here? Well, we do know that strabismus and amblyopia occur in about 5% of the population, and that there are certain nature and nurture components to it. The work from Richard Brunik in Norway showed us a lot of the genetic areas and how that happens in the extraocular muscles, why some patients seem to be more at risk than others. But there's also a pretty large nurture component, environmental component to this as well. And we know that often, if there's asymmetries in development, we can see patients at higher risk for developing amblyopia and or strabismus. And asymmetries in development are things like what I alluded to earlier. If there is asymmetry in hearing early on in life, if the patient crawled asymmetrically, so for example, if they kind of drag one side of their body, almost kind of Igor look as they're crawling, that is a higher red flag. If there was a hip dysplasia and the patient had to wear a lower body cast early on in life, or certainly if there was an injury to one side of the body early in life, all of these things that cause asymmetry in the body or in development can cause asymmetry in vision development as well. But generally speaking, if something is going to be persistent in a population, and if you think about it, 5% is a fair chunk of people. This is a big part of the population. If it's this pervasive, there's usually some sort of benefit to the species for those individual organisms that possess that trait. So what could possibly be the benefit from strabismus or amblyopia? And what we do know is that there are some things that, genetically speaking, that sometimes kind of pop up in a population that we think, oh, that's terrible. It's, you know, these poor folks that have it, they kind of lost the genetic lottery. But they do actually have some benefit in other ways. So a good example that I know of is sickle cell anemia. So with sickle cell, we learned about this a lot in optometry school because of the terrible issues that can happen in the retina and certainly systemically for the folks that are afflicted with it, that are born with it. But the benefit of it, not that it really matters so much now in the Western world anyways, these folks are fairly immune to the effects of malaria. And so although it might be pretty terrible in some ways, in at least one other way, it is a benefit. So if we look at it, strabismus from that standpoint, what could possibly be the benefit to these folks for having strabismus? Why would we want this? Well, we do know that if binocularity is poor, there's going to be intermittent sensory conflict between the two channels. What does that mean? Well, if I have an image from one eye and have an image from the other eye, and they're supposed to be sandwiched together, right? And to make a single fused image. Well, if I have binocular instability, then what I might have going on is something like this, where it's just generally uncomfortable to look at, or even this, or this, okay? And what's going to happen is it's going to stop making sense. And when that happens, there is this desire to resolve the conflict, okay? Fix it, make it right. It's too complicated to try and interpret what it is that we're seeing when the world is kind of messed up like that. And so one way that we can do that, one way that we can solve the conflict is to suppress the image coming in from one channel. And if you repeat that often enough, then it can become habitual. And so we start to habitually suppress. Well, suppression is an active process, okay? It takes a lot of brain power to inhibit all of that visual information coming in from one channel. That is an exceptionally large ask, and it's very difficult to maintain over long periods of time. And so what is a better way to solve that problem rather than physically shutting down or mentally shutting down, voluntarily shutting down that whole channel? What can we do instead? Well, if the patient is unable to resolve that sensory conflict on their own and they try that active suppression, realize this is too costly from an energy standpoint, we need to figure something out to do for the long term. So if all I do is occlude one tiny area, okay, shut off the part that doesn't make sense, and I can still use the rest. So in this picture here, you can see that no matter how you look at that top picture, you can't make it make sense. Okay, this is not something that can exist in the real world. But if you just block that one little tiny section, everything else makes sense. And so strabismus is a benefit because it is developed to preserve our binocularity, okay, not to destroy it. So if all we have to do is turn the eye a little bit so that we park that macular area and hide it behind the blind spot, then it's not a problem anymore. Or if you're really little and you're not really sure how to do that, the easiest way to do it is just block it by the nose, use the nasal blind spot. So it's a much less costly way to kind of block that suppressing area. So with your anomalous projection, you know, it used to be that if you had anomalous projection, then you were kind of out of luck, right? And no one would touch you with a 10-foot pole. You can't do VT, you're just broken. But really, we should not think of it that way. It used to be thought that, you know, anomalous retinal correspondence meant that there was some rewiring that took place and the macula is not working. And so there's some sort of new macula rewired in the brain. And we know now that that does not happen. Anomalous projection, you can diagnose again with your Worth 4 dot. And I actually think of this as a positive prognostic indicator for vision therapy. What it's telling me is that the patient knows that what they're seeing doesn't make sense intellectually, and so they are fixing it themselves. They are kind of rebuilding their visual world in a logical way that they know makes sense, even though they're not seeing it that way. So really, whether you choose to look at it that way or not, it really doesn't matter. At the end of the day, just remember that these patients can be helped. But it does need a proper kind of VT clinic. This is not something I would do in a private practice setting. So a little bit more about surgery. And I do have the study references for these. So if you're interested, I can certainly, you know, pop me an email and I can send you the studies on this where I got these stats from. But when you are cutting the muscle and repositioning the eye into a new location, remember why the patient developed the strabismus in the first place, right? They put it there because they needed to resolve that sensory conflict. If we realign the eyes, but gave them no method of resolving that sensory conflict, the best thing that they know how to do is just put it back, okay? This is kind of like the folks that have gastric bypass and insist on still eating larger meals. Eventually, they're going to stretch out the stomach again. And it's kind of very much the same thing here. If we don't give them another strategy to resolve that binocular confusion, it's going to fail. Okay? And we know that 77% of strabismus surgeries fail within the first 3.5 years, okay, unfortunately. And even with 2 surgeries and Botox injections, the failure rate is still 73%. Okay? But this is something that a lot of the patients don't know before they do it. So whenever my patients ask about surgery, I will give them all the information I can give them about it. And I will tell them, your ophthalmologist will likely tell you that vision therapy is not going to work for you. What I would like you to ask your surgeon is, what is the likelihood of needing another surgery? How long until my child needs another surgery? And will my child develop good binocular vision and have good visual acuity in that eye? And that's certainly nothing that they can promise necessarily with surgery. It's just not there. Also with surgery, we get the nice fun stuff. And this is the kind of double vertical deviations and your consecutive exotropias where they started out as an ESO and went to an EXO. So with your amblyopias, you also, again, are finding that about 5% of the population is going to have this. It is best corrected acuity worse than 20/30 or separated by 2 lines, but it's in the absence of pathology. If there is no amblyogenic factor, then you cannot call it amblyopia. And I like to think of this as a Z-axis strabismus. So, X is your exo and eso, your hypo and hypo, or your Y-axis strabismus. And you can think of amblyopia as your Z-axis strabismus, which I think is a nice way to think of it. So this is one of my patients that I had a few years ago, 5 years old. He came to me for a second opinion, and he was told to patch one eye at a time for 2 hours each day. And he was given glasses, which he would wear. And mom didn't bring them to the appointment because she didn't want it to, dissuade me or somehow make it that I would prescribe something similar. So he had actually been seen when he was 2 years old once previously at our office by another OD. And there was a whole lot of the word uncooperative written across the chart, as one can imagine with a 2-year-old eye exam. But what they did get was a static ret of about +2 - 1 and +2 25 - 1. So pretty symmetric. When I saw him that day, I measured 20/50 and 20/40 in acuity, no strabismus, 6 diopters of exo at near. On stereo and worth 4, we had right suppression. But look at this ret. Okay, so we had right suppression. And yet when we look at the amount of hyperopia, we have increased hyperopia on the left eye with a best corrected acuity of 20/20 and lower hyperopia on the right eye, the eye with the suppression, and a best corrected acuity of 20/30. So this does not smell right to me, and I do not want to do anything with this patient until they have been medically cleared. And so I sent them to their family physician, asking for a neuro consult, because where we are, we cannot refer direct to neuro, nor can we order our own imaging. Sad but true. And so I can only refer back to the family doctor or an ophthalmologist. So I asked the family doctor to get this person some neuro testing. Turns out he came back 5 months later. The neurologist had said that they were not concerned, but the family doctor referred the patient to an ENT, an ear, nose, throat specialist, because he had fluid in the right ear without infection. And the ENT actually found a chronic right tonsil enlargement that had gotten so big that it actually encroached into the right middle ear, if you can believe that. He had his tonsils removed, and the ENT actually diagnosed him with a right amblyopia, which I learned at the time is like amblyopia, but for your ears. And he underwent auditory rehab therapy. When he was done, he actually presented back again with the same retinoscopy findings, only his best corrected acuity had switched, and he presented with a left amblyopia. And he did vision therapy, and he did quite well. So your non-strabismic disorders, again, I don't want you to get too caught up on how much base out until we can diagnose this person with convergence insufficiency or excess or whatever. Treat the patient, not the syndrome. Okay, if the patient has symptoms and they have abnormalities in testing, then it can be managed with glasses and or vision therapy. You don't have to memorize specific criterion. Okay. With your fixation, when patients have abnormal fixation abilities, we do kind of see these patients being diagnosed potentially with ADD, ADHD, or they're just kind of mislabeled as being the bad kid, the poor listener, the daydreamer. They're being rude because they're not fixating. So keep that in mind, that if you're getting these things in the history, it may not be that they have these issues. It may be that they are not able to keep their visual attention where they want it and their fixation is poor. So I put the diagnostic criteria for the vergence problems here if you want them, if you're concerned by them, but just kind of note the symptoms for all of them. Okay, they all potentially can cause headaches, asthenopia, reduced near point efficiency, blurred vision, near aversion. So it doesn't really matter whether it's a CI or a vergence in facility or whatever the case may be. These are patients that are going to be suffering and they're going to be inefficient close up. And regardless of which flavor they have, the treatment is going to be the same. And because VT is not physio for the eyeballs, we don't have to worry about making sure that we only do base out if the patient has CI or only do base in if the patient has CE, because we're not trying to build ranges, we're trying to teach the visual process. And that's something that the patient has to learn themselves. Same thing goes for your accommodative dysfunctions. So I've put the kind of the findings that you might find depending on which flavor of accommodative problems there are. But again, just kind of take note that the symptoms are often fairly even, like, fairly stable across the whole board. Keep in mind, though, your accommodative excess or your accommodative spasm. The symptoms can include blurred vision at distance, right? And so sometimes the patient's coming in and they complain of blurry distance vision, and we say, oh, brand new myope, let me get you some glasses. And if we haven't really assessed the patient for binocular dysfunction, we could potentially be misdiagnosing them. So something to keep in mind there. For your POR and SUPO scores, or if you are measuring using the developmental eye movement test or using a readalizer, this is where you're going to find your ocular motor dysfunctions. This you really do need to treat in a VT setting, so I'm not going to go too much into it under primary care. But if you found your NSUPOs to be abnormal, this is potentially the diagnosis that you are looking at. So this is where I wanted to get to in our treatment session. And again, knowing what you can do in a primary care setting is really important because it's probably more than you think. And let's get into another poll here, because I'm curious to know which you would feel comfortable treating if they walked into your office today or tomorrow, I guess. Okay. So I'm glad there's not too many in the bottom, 7%. We can work with that. But yeah, CI is one, and your accommodative issues are generally ones that are managed fairly well in a primary care setting. I would argue that amblyopia is as well, although I didn't put it on there on purpose. We will get there. Thank you. So let's look at that patient, and we all have that patient. We hate that patient. They come in and they complain of blurry distance vision, right? And then when you put up the distance acuity, they rhyme off the 20/20 line like it's no problem. And yeah, 20/20, blurry vision, haha, very funny. But this is almost always a VT or a BV problem, I should say. And this is one that absolutely is very, very manageable in a primary care setting. And these patients respond very, very well to actual near point lenses. And we'll talk about that in just a second. So generally speaking, when we're prescribing lenses for BV issues, we are going to be prescribing Trivex, not polycarb, okay? Trivex is just as safety rated as polycarbonate is, but without all of the distortions and aberrations in the lenses, okay? So I do not prescribe poly, and I will write no polycarbonate on all of my prescriptions. I don't care how many opticals hate it, that's just what I do. If I'm going to be giving a bifocal lens, it is a flat top. It is, or a round, but it is not going to be a progressive, and it's not going to be one of the dynamic ab lenses. Why is that? Well, if you have a presbyope, if they are not using the lenses properly, they can't see. And so they learn, right? They learn how to use them. But a 7-year-old, if they need to be using an ad of +1, how on earth do they know if they're actually in +1 or if they're in +0.5 or +0.25 for that matter? They need to be on the face correctly, and the patient needs to be using them correctly. And you really just can't count on kids to do that. Plus, we're trying to get them to move their eyes free from their head. And what do you have to do with a progressive lens, right? You have to point your nose at what it is you're wanting to look at. So no progressive lenses and dynamic ad lenses are the same. Not to mention all the induced prism that comes from it. So if you have a patient who is in grade 2 or less, I'm going to split the pupil with the line in the bifocal, just to make it super, super easy to know how to use that lens. If they're in third grade or above, then I will set it at the lower lid margin like a normal bifocal. In doing your subjectives, some things to aim for. If you have a bias in prescribing, meaning if you give the patient two choices and both choices are pretty much the same to them, and it's up to you to pick which way you're going to lean to whichever lens is closest to plano, lean to whichever has the least amount of sill, to complementary or equal axes if you can. So for example, 80 and 100, 170 and 10, 105, 75, that kind of thing. Equal amounts of sill, if at all possible, the least amount of anisometropia, or the axes adding up to 180. So again, not to change the patient's prescription, but if there's a bias and it's up to you to make the choice of what you're going to prescribe, then lean toward these findings, just to keep things as symmetric as possible for the patient. Now, when it comes to ads, bigger is not better, okay? So if you have a patient with poor accommodation, we are not going to beef up that ad because they're not able to do it on their own. We are trying to get them to learn how to use their visual process a bit more efficiently, and we don't want the lenses to do the whole thing for them. So this is an example patient. We're going to go over a sample patient more in a second. But if the chief complaint is blurred vision at near, and they're basically 20/20, but with a subjective RX of -1/4 OU, I am not going to give that patient distance lenses if I can help it. Because I know, based on my other BV testing, I'm expecting things like a higher EXO or an ESO for that matter, or a poor NPC, or any other host of issues. That this is a patient who could benefit from a near point lens. And once they adapt to using that plus at near, those distance symptoms are probably going to go away. So I don't want to force them into a minus lens, or not force them, but give in to giving them a minus lens that they're then going to be saddled with for life. If I could just buy a little bit of time and get them back below that minus. Your patients are going to be at highest risk for progression if they are ESO at near on cover test, if they have a close habitual working distance. So if you give them that near card, the reading card, and they're holding it up here habitually, then that's a red flag. If they have that low PRA, or if they're that, stereotypical minus hog, more minus is better, no matter, forget the fact that it doesn't actually improve their acuity any better. They just like it. These are all warning signs that the patient may progress in myopia, and they could benefit from an ad. So let's do a little sample case here. We have 12 years old. The teacher noticed squinting at distance. We have an unaided ODOS acuity of 20/25, but we're 20/20 minus OU. We have reduced stereo. Okay, we have ortho at near. We have some reduced ocular motility issues. Okay, 433 there on your NSUCO scoring. We have mild myopic changes on our RET and subjective. We have a low PRA, and we have a lag of accommodation of 7.75. So what I might be prescribing for this patient, given the fact that they have that ortho at near, the low PRA, that minimal gap, less than 4 diopters between NRA and PRA, that they seem to enjoy the minus, we can either just tell the patient, look, I need you to sit closer to the board, but I'm not going to give you any distance glasses at this point. You're going to talk to them about visual hygiene, but you are going to give them a near point lens. And so if they really, really want, if they won't stop talking about the need for distance vision, I might give them that 1/4 with the 75 ad, or I'll give them plano with the half diopter at near. So I'll give basically just enough to kind of get them moving a little bit. It's just to kind of nudge them into the right direction. It's not to get the lenses to do all the work for them. And what I'm expecting is for this patient to come back after about 3 months' time with normal or restored distance acuity. If it's no better, if it hasn't changed at all, probably what that means is that they weren't wearing the glasses. And if their distance vision gets worse, even with those lenses in use, then at that point, I would either refer for VT or to a myopia control colleague. We know that even small amounts of myopia are just kind of a gateway, and they're likely not going, at that age, not going to stabilize very quickly. We want to kind of nip that as much as we can. Now, we only have a couple minutes left, and I do want to talk about amblyopia, so I might sneak 5 minutes into the question period. But I want to talk about amblyopia because I know there are still those among us who use patching for treatment of amblyopia, and it really does not make sense to teach a patient how to use both eyes together by depriving one eye of light. That's kind of at its core. Patches are for pirates. Okay. This patient needs specialized prescribing. Why are patches for pirates? There are a number of studies that show us that the benefits of binocular training are much, much better than those of patching, both in terms of how long it takes for patching versus VT, the fact that the recurrence rate is high with patching and not with binocular training, and the fact that you can do this on any age of patient versus for patching, which really has only been shown to be effective in age 17 or less. So I put the study reference here at the bottom for you to kind of go through and read this. It's a very long study, but very, very worthwhile reading. And I hope you get to that. And this is where that cyclo comes in, right? Because that's kind of what we were taught, right? Cyclo plus and patch. And what I want you to consider is this case here. So a patient with an unaided acuity in the left eye of 20/80 presenting and 20/20 in the right eye. You do a RET and find 350 in the left eye, which gives you a 20/40 acuity. And when you do the cycloplegic refraction, you find a +6 also to 20/40. Okay. What we never do, though, is have the patient back the next day after the cyclo has worn off and see what that prescription would actually give them in terms of acuity. Okay. And I'll tell you, because I have done that, I get the wet refraction and then I have them come back the next day and I trial frame what I was planning on prescribing them. And you know what? The acuity is worse than 20/80. It is worse than being unaided. And so it kind of gave me a eureka moment, like, why are we doing this? Why are we prescribing these large amounts of anisometropia for patients, patching them for good measure, shoving it down their throat, making the parents deal with it, and telling them, you know, you're not being cooperative and compliant, and that's why it's not getting better. And really, this is hard for families, it's hard for patients, and it's not fair, and there is definitely a better way. So I hope that what we can do is kind of look at this next case here with a little bit more critical eye in how it is that we're prescribing for these patients. So this is a real patient. JG came for his first eye exam. Lo and behold, 20/80 presenting. With dry RET, he was +4, and that only improved his acuity by about a line. But if I took it all out of the phoropter and did a subjective starting at plano, what I found was +275 in the left eye. That gave me an acuity of 20/50. Okay, so 2 lines better with less plus than what I measured with my retinoscopy. Now, I also did a trial frame on the right eye, so the non-amblyopic eye, and I'll talk about that in a second why I did that. And what I found was that if I put 0.75 in the right eye, I got 20/25. If I put +1 in the right eye, I got 20/40. So a big jump there between 75 and 1. He had no stereo, he had suppression. And look at the wet. So the wet RET in the left eye was 475, and that gave us 20/60. Okay, so here's where I'm going to ask you, what would you prescribe here? So here's our next poll. What are you prescribing? How do you do this? This is your patient sitting in front of you. You got those numbers. What are you going to do about it? Okay, so we have more people cutting their plus, which I like to see. I'm curious as to the others. I wish that we could chat in person to see what you do. But I'm glad that we don't have too many people that are just prescribing their wet and calling it a day. again, it's kind of leaving the patient with the most anisometropia possible here. So what I did give him as a final RX was 0.75 in the right and 250 in the left. In a Trivex lens, full-time wear, recheck 3 to 4 months, and tried to get him into VT. Now, they did not want VT, but we'll talk about why it is that I prescribe that. So this is just a quick diagram to show you the difference there between poly and Trivex. Definitely Trivex is the way to go if you need to do a safety rated lens. So for our left eye, both the left eye in the wet and the dry gave us an acuity of 20/60. And so there's really no need to increase the amount of anisometropia or plus when there is no benefit in the acuity. Okay. So 275 gave us the best possible visual acuity. And so I dropped it by a quarter just to give him a little place to move to. So essentially what I'm doing is giving the best visual acuity possible in the amblyopic eye. For the non-amblyopic eye, what I want to do is notice the fact that I get 20/20 anywhere between plano and 50, okay? If I give 75, I'm dropping the acuity to 20/25. If I gave him 1 diopter, then I drop the acuity to 20/40, which is a bit much. So what I want to do is give the patient the lens which provides the best corrected visual acuity with the lowest possible power in the amblyopic eye. And we're going to aim for about 20/30 to 20/25 in the non-amblyopic eye. And what this is going to do is put the patient into a slightly submissive position with that non-amblyopic eye and let them start to rebalance. So the brain can start to attempt to use the other eye, a little bit the amblyopic eye at distance, and there's much less anisometropia for the patient to deal with. These lenses are absolutely much better tolerated than the large amounts of aniso. And because they have increased amounts of plus in the non-amblyopic eye, their near acuity is actually better than it was before, because it's kind of like having a little bit of an ad. Now, the patient didn't really go for that. They went for a second opinion instead at another office, someone who prescribed the Cycloplegic. And lo and behold, he would not wear the glasses, but he did wear mine. And so the patient ended up coming back to see me longer than what I had wanted, 6 months instead of 3 months. But they brought the other prescription and said, you know, he wouldn't wear these, but we'll try it your way, but we do not want to do VT. We don't have the time. He's in rep hockey, blah, blah, blah. So fine, I did a new exam. And what I found was that when he came back wearing the glasses that I had prescribed, all of a sudden now with the glasses, he's 20/40. Okay, so he was 20/50 before, 20/40 now. I got a new subjective of 20/40 with that 250. And what I found was he was able to accept a little bit more plus on that non-amblyopic eye. So the new prescription that I gave him was +1 in the right, plus 225 in the left, and to have him back in another few months. And so we repeated that process, 3 to 4 months, recheck, readjust the prescription to maintain that balance. And after a year and a half and 4 glasses changes, he's 20/20 in the right eye, 20/20 -2 in the left. He has 50 seconds of stereo, and he's wearing 1.5 OU. Okay, 1.5 in both eyes. His wet ret is now 175 and 275. So yes, he still has some aniso, not nearly as much as he had before. And he's wearing equal lenses in both eyes with 20/20 minus acuity. So this is something that we are going to be able to do absolutely in a primary care setting. You do not necessarily need VT, although they do respond a lot faster if they do vision therapy. And they're going to be a lot less likely to regress. So for this patient, anyone who uses this method for your anisometropic amblyopic patients, they need to keep wearing those glasses full time or they're going to slip, depending on the age, but they're going to be at higher risk of redeveloping amblyopia if they stop wearing those lenses. So vision therapy, if you're going to do it in your office, this is generally, depending on the office, an hour once a week. There's going to be about 15 minutes of homework prescribed. And again, this is going to depend a lot on the patient and on the office. Simple stuff is usually about 20 weeks in length, like CI. For your amblyopias, strabismus, your acquired brain injuries, it can be longer, a year, even beyond for your really stubborn cases. There are so many studies that are already out there, so I really don't like to hear that VT is, all that bunch of hooey that is unproven and no one does anything about it. Check out the visiontherapycanada.com website. There's mountains of studies there, guys. Honestly, you can spend hours reading stuff, and I hope you do. I know the COVD website also has tons and tons of research, so please do look it up. I have one more poll here before I shut up, and I hope that we got some stuff out of this here. And let's see where we're at. All right, only 1% has their fingers in their ears. That's really my goal there. So some more educational opportunities for you guys if you are interested in learning more about BV and VT. There really needs to be more of us practicing and doing this, because we have, especially now with COVID, there's patients out the wazoo and not enough people there. My email's at the bottom. Please do email me with more questions.